Good morning. May I have all primary speakers to the podium? Good morning. If everyone could please settle down, we're going to start. Okay. Good morning. My name is Felicia Eggleston. I'm your moderator for today, and I'm also the team lead here for Part B Drugs. Welcome. This meeting is being webcast via CMS. The CMS webcast is live, so it begins as our meeting begins. By your attendance today, you are giving consent to the use and distribution of your name, likeliness, and voice during this meeting. You are also giving consent to the use and distribution of any personally identifiable information that you or others may provide during today's meeting. So we ask that you please do not disclose any personal health information. This webcast can be found in archives after the meeting on YouTube or the CMS Ustream website, and we believe that it's there permanently. So I'm going to go over several housekeeping items. So if you need to go to the restroom, you'll go out to my left, your right. You make a right turn, proceed down the hall, restrooms on your left. If you continue out to that hallway that brought you in from the lobby and make the left and go out and then make a right past the elevators and continue on down the stairwell. To the left, you'll see our Jazzman's cart, our little coffee stand, as well as our cafeteria. So for security reasons, we have been asked to remind you that you are only allowed in the public lobby areas of the building, which is the main lobby and the lower lobby. If you're going anywhere else in the building, you need to be escorted by a staff member here. So if you need any assistance in arranging for a taxi today, please see the concierge at the front desk. CMS is a non-smoking campus. There are smoking areas designated outside of both of the entry gates. We'd like to ask at this time that you would please put all cell phones and BlackBerries on silent. We'd like to also ask that all speakers, including those answering or asking questions, please be sure to step up to a microphone so that everyone can hear you. So it works this way. Primary speakers come up to the podium. You speak from where I'm standing. If you're a 5-minute speaker, we'd like to ask that you use this microphone that sits right in front of the stage area. And if you have questions, if you're closer, you can use the one here in the front or the one that's in the middle of the aisle there. All right. So we'd like to ask for everyone's cooperation in adhering to our speaking times here. Primary speakers, you have up to 15 minutes. 5-minute speakers, you have up to 5 minutes. I'm going to be keeping your time today by our stop clock that's here to my right, your left. So as you're speaking for primary speakers, if you would just glance back and forth, to the clock. Once you get to the 2-minute mark, you'll hear me gently whisper 2 minutes. Unless I hear keywords that says summary and closing, I'll say 2 minutes. That's your key to begin wrapping up. 5-minute speakers, once you've exhausted your time, I'll simply stand here, and that lets you know that your 5 minutes has been exhausted. Speakers may not call on other speakers. You may not designate any unused time. Only I, your moderator, can call speakers to the podium. We will call a coffee break and a lunch break, time permitting, as the meeting goes along. So at this time, I'm going to introduce Cindy Hake. She is the Deputy Director of CM's Division of DMEPOS Policy and of the CMS National Level 2 HCPCS program. She will provide opening remarks and a brief description of the background and purpose of today's meeting. Cindy.
Good morning, everybody. Good crowd today. Maybe one of our biggest. Thank you for taking time out of your busy schedules to join us here today for our HCPCS public meetings. Today and tomorrow, actually, it's a 2-day meeting for durable medical equipment, orthotics, prosthetics, and supplies. And so some of you may be planning on joining us tomorrow as well. Feel free. This public meeting forum arose out of BIPA 2000 requirement pertaining originally to durable medical equipment, that CMS have a forum for discussion of coding and Medicare payment for all new durable medical equipment. And that's how we began. Our first public meeting was, I think, 2004, and we had one DME item on that agenda, so that's way back there. And the meetings grew from there. We recognized the value of the meetings for us, and we think for our audience as well. And so we expanded the forum to take public comments on HCPCS code applications of every category before us. And so we've grown to having about 5 or 6 public meetings every year now about this time. Before the public meetings, CMS's HCPCS work group reviews all the applications before us and formulates the preliminary coding decisions that you see before you. We have internal input for the Medicare payment preliminary decisions. The work group includes members who provide input based on their perspective of the national program operating needs of all government and non-government insurers, just so you know. So we have folks from Medicare, Medicaid, private insurance sector, Veterans Administration, and DOD all coming together to look at your applications relative to their national program operating needs. We publish our preliminary decisions along with our decision-making rationale in advance of the public meeting. You've seen those decisions probably online, and they're also in the agendas that you have before you today. And then via this process, we invite testimony from really anyone, the general public, applicants, national stakeholder organizations, reimbursement representatives, other stakeholders and interested parties come to this forum and provide input to us, and we receive written comments in addition. After the public meetings, the HCPCS work group reconvenes to reconsider every application before us, together with any input that we received as we begin to formulate our final decisions. So final decisions are not made at these meetings here. These are not decision-making hearings. We've put our cards on the table. You have our preliminary decisions with you, and we're here to take your input today. What will happen next after these meetings that you'll see is that we'll publish summaries of these public meetings sometime in August. They'll look very much like the agenda that you have before you, only we will add to it the key points made by any primary speakers who come to speak on behalf of the applicant. So not to misconstrue, so in August we're not publishing decisions, we're publishing a summary of the public meeting proceedings. Final decisions then are published around the first week of November in a variety of ways. We publish CMS's HCPCS annual update. In addition to that, we publish a running record of the applications that again look like the information that you have before you. In addition to that, they'll include the primary speaker comments, and then they will include our final decision and rationale. And we publish that in a text format and also in like a spreadsheet format on our website. And in addition, we mail individual decision letters to every applicant at about the same time the annual update is published. So today is your day. We really do appreciate the diverse input that we receive at these meetings. Sometimes we do change our minds based on the information that we get at these meetings, so we think the process works for you as well as for us. We hope you have a good day, and I look forward to your participation. Again, thank you for coming.
Thank you for that overview. At this time, I will introduce Joe Kaiser. He is the Director of the Division of DMEPOS Policy. He will provide an overview of payment for DMEPOS payment. You will also see a more detailed description of the payment of DMEPOS items attached in your agenda at the end. Joe?
Hi, good morning. For Medicare, for durable medical equipment, prosthetics, and orthotics, we have exclusive payment rules in the statute. Social Security Act mandates that the payment amounts in areas outside of competitive bidding or for items that are not subject to competitive bidding the payment amounts be based on fee schedule amounts. We pay the lower of the actual charge on the claim or the fee schedule amount. Now, fee schedules began in 1989 for DME and prosthetics and orthotics. This was based on legislation from 1987. Legislation mandates fee schedule amounts based on 86-87 data. That was the most current data at the time. And the statute also mandates that the fee schedule amounts be updated annually by a covered item update. This is the exclusive payment rule for Medicare, so there's no discretion. We pay based on the rules of the statute. We also have competitive bidding programs throughout the United States for certain DME and for enteral nutrition. In those cases, there are different payment amounts subject to the rules of those programs. Beginning in 2016, for the items that are subject to competitive bidding, we use information from the competitive bidding programs to adjust the fee schedule amounts in the non-competitive bidding areas. So with regard to HCPCS, certain payment determinations result from different HCPCS coding decisions. In all cases, the payment determinations, need to ensure the continuity of the statutorily mandated pricing of the items and services. So if the coding decision is to use existing codes, then the payment amounts and the rules for that code would apply to the item. If there's a decision to make an edit to the HCPCS to have a coding change, then there are different rules that apply to the different types of coding changes that are required to ensure continuity of the statutorily mandated pricing. When a code is exploded into several codes for the components of that item, we would establish fee schedule amounts for those components so that the sum of those fees equals the fee schedule amount for the previous code. If there is a single code that describes two or more distinct complete items, and that is exploded, that single code is exploded into two or more codes for similar but different items, then the continuity of pricing rules are that we take the fee schedule amount from the one code that was exploded and apply that to all the new codes. Then conversely, you may have two implosion scenarios, one where components of an item are imploded into one code. In that case, we would just sum up the fees for the components to establish the fees for the new code. And then you have the situation where you have two or more similar but different items that are then imploded into one code. In that scenario, we take the weighted average of the fees for the different items to come up with the new fee for that one single item. So a couple of things. The HCPCS process is not a coverage determination process. There's a statutorily mandated process that we have to go through to do national coverage determinations. Secondly, the HCPCS process is not a process for increasing payments. There is a separate process in the statute where if the 8687 charge-based payments updated by the update factor are grossly deficient or grossly excessive for items and services as they exist today, we go through a process known as inherent reasonableness. And that process is the process that's mandated by the statute to have an increase or a decrease in payment for a category of items. For newly covered items, so this is brand new, never seen before, not a coding explosion, not a coding implosion. For the newly covered items, we will base the fee schedule amounts on fees for comparable equipment. That way, we're still using the 8687 data that the law mandates to price this DME or prosthetic or orthotic item. And thank you very much for coming, and we look forward to your input. Thank you.
Thank you for that payment overview. Next, I'd like to introduce several of the HCPCS team to you. We have our HCPCS work group coordinators. As I introduce them, I'm going to ask that they stand. First, we have Ms. Judy Wallace. Nathan Howman, and Kimberly Combs Miller. So many of you may have had the opportunity to speak with them at one time or another regarding your HCPCS application. They worked very hard to put together all of the details to make it necessary for us to have this meeting today. So we're grateful for them. Thank you so much. All right. So next, I would like to introduce our medical advisor to the HCPCS work group. She is Dr. Preeta Chidambaran. And finally, last but not least, we have Mr. Charles Hirsch and all of his team members that work behind our booth here, and they provide all of our audio-visual presentations. So we're going to begin this meeting. Everyone should have received an agenda when they came in. If you did not, there should be some still available out on the table. For each item on today's agenda, you will find a written summary of the HCPCS application, and it will include CMS's preliminary coding decision. So the meeting will proceed one agenda item at a time until we have completed the agenda. We will hear a presentation from a primary speaker if there is one, as well as any 5-minute speakers if there are any. Okay. We ask that every speaker will state who you are, state who you represent, state your relationship to the applicant or to the manufacturer, declare in your oral presentation and in your written summary whether or not you have any financial involvement with the manufacturers or competitors of any items or services being discussed today. This includes any payment, salary, or other benefit that may have been provided to the speaker by the manufacturer. We'd like you to also state whether you agree or disagree with the preliminary decision, and when you summarize your comments, please state your rationale for agreement or disagreement. After we've heard from all speakers, we will open it up for discussion and questions. So, now we're going to start with agenda item number 1A, application 17.005, request to revise existing level 2 HCPCS code A4604. There are no speakers for this item. Are there any questions or comments? Agenda item number 1B, application 17.81, request to establish a new level 2 HCPCS code to identify Ostem Eye alert sensor. Primary speaker is Mr. John Aforismo.
Hi, good morning. I'm John Aforismo. I am consultant to 11 Health. I do not have any financial input with the company, but I am paid as a consultant. A little explanation. The Ostem Eye Alert was developed by 11 Health Technology out of London, England. The owner and CEO is Michael Sears. Michael Sears was the 11th person in the UK to undergo a small bowel transplant and also an ileostomy. The Ostem Eye Alert was developed by Michael for himself so he could be able to measure the output and flow coming out of his ostomy so it could be reported back to his physician. I'm here today to ask for you to reconsider the application and provide us with a specific code for this product. The Ostem Eye Alert sensor is part of a clinical management program, and yes, we originally received the code back in 2016 as an alarm, and that part of this product, it does act as an alarm. The tagline for this product is, we measure it so you can manage it, and I'll explain who the you is. Okay, the Ostem Eye Alert is a discrete device that is affixed to the outside of an ostomy bag, such as this that I'm holding up. The bottom one, which is blue and the blue clips, this was the original device and the original pictures that we submitted with the application. However, the red tag is the more secure device, and this is the one that is now being trialed at Stanford, Mass General, and a number of hospitals across the country, and is being ready for release. This device will send a Bluetooth message to an iPhone, an iPad, and the patient has the ability to decide and determine when the patient wants to know when it is time to empty his or her bag. Again, we developed it, and it has been developed to eliminate mishaps for the patient. In the meantime, all this data that is being generated at the time for the patient, all the output readings, time of output, the volume of output, and whether it's solid, liquid, or gas, is being transmitted to a cloud, which is HIPAA compliant, and the physician, nurse, caregiver, and the patient themselves have access to this information. It will allow the physician to manage the hydration of the patient and understand if the patient needs more fluid, and also can regulate medication management for, as I said, it provides to the nurses and physicians to manage dehydration and electrolytes. A patient does not know when they are eliminating waste. This is the main issue as well. The nerve endings, the sensitivity issues, so the patient needs something to alert them to this fact. Here is just an example of what the data will look like and does look like when a physician taps into the dashboard or the patient taps into the information. It will tell them various spikes and so forth of when waste is eliminated, how much is eliminated, time and so forth. And it can be managed by, we could look at 24-hour output, we can look at 12-hour output depending on how we're doing it. Again, I should have mentioned my role with the company also is to develop the analytical management. So we develop different graphs and reports that the physicians and patients and caregivers can utilize. Okay. Coding history. The application was in January 2nd of 2015. We submitted an application, and we were awarded A9280, which is an alarm excuse me, device not otherwise classified. When we looked at how Noridian crosswalked this product, they crosswalked it to a number of alarms. And some of those alarms were alarms for people that were laying in a mattress. So if they moved, the alarm would go off, and a nurse or caregiver would know that somebody moved, so to go in and check the patient, as well as bedwetting devices as well. December 29, 2016, we sent another application in for reconsideration, so we would get a specific code for the Ostomy Alert sensor and management system. In looking at some of the other codes that are in the system that CMS has awarded, there are many different codes for devices that will monitor and give information to patient management. As a pharmacist, and I've worked with diabetic patients many, many times, using diabetic monitor systems, I know exactly what they do and how we transmit that data to patients, as well as how physicians and diabetic nurse educators would use that. But here are a number of other codes that have been awarded that we believe our system, or the Ostomy Alert, is part of this patient management system. In summation, it's the first in class connected medical device. It will address dehydration, electrolyte imbalance. It manages medication use. It helps with readmission rates. And what we're finding from our studies at Stanford and Mass General is that the patients who are utilizing this, the readmission rate for those patients or for those operations have been gone down 34%. So it helps help the physicians and nurses manage patient management. Finally, patient mishaps. It has helped with our patients so at night they can sleep and get rest that they need. We even have students, high school students, who are using these devices just for the simple reason that it allows them to go out to have dinner with friends, and they can manage what their output is and so forth. And again, it improves the quality of life. So I guess in summary, I'm asking for the HCPC committee to reconsider with the information that was presented, and thank you very much. Anybody have any questions? Thank you.
Agenda item 1C, application 17.85, request to establish a new level 2 HCPCS code to identify the Gentile Lansing device. There are no speakers for this item. Are there any questions or comments? Agenda item number 2, application 17.6, request to establish a new level 2 HCPCS code to identify novel CC. Primary speaker is Mr. Christopher Salomon.
Good morning. My name is Christopher Salomon. I am an employee of ResMed, and I'd like to thank the HCPCS work group for giving us the opportunity to give some input today on our Narval CC coding application. This is Narval CC. It is an oral appliance. It is custom fabricated, and it reduces the collapsibility of the airway by adjusting these titrating rods here. Under normal circumstances, most people would think that this would fit code E0486 because that is the definition of E0486, is a custom fabricated oral appliance that reduces airway collapsibility and is adjustable. However, there is a policy article, A52512, which narrows the coding definition for E0486 to a device that has a fixed mechanical hinge or an inseparable pivot point. I want to tell you a little bit about the history of this before I get into why we asked for the coding application today, because we've requested 3 times for this Narval CC device to be coded as E0486, but every time that we've requested it, we've gotten a non-covered code, or A9270, because it does not have a fixed mechanical hinge or inseparable pivot point. So that's a little background on why we're here today and asking for a new code for an oral appliance with a non-fixed mechanical hinge that is adjustable and is custom fabricated. We request the HCPCS Coding Committee to reconsider their preliminary recommendation not to establish a new code so that beneficiaries may have access to this device. In summary, the reasons that we request this is OSA is a serious medical condition that adversely impacts the overall health, and MRDs effectively treat OSA, such as Narval here. OSA patients come in all shapes and sizes, and each patient needs to have a device that's fit specific to them. Additionally, this policy article has effectively restricted and narrowed the coding definition of E0486. And so, de facto, E0486 has now been narrowed to a device that has an inseparable pivot point and a fixed mechanical hinge. And so we're requesting a code for a non-fixed mechanical hinge. Before I get deeper into the arguments behind this, I want to make sure that we're all on the same page with ResMed, OSA, and MRDs in general. ResMed. We've been doing sleep disordered breathing for over 25 years and are the market leader in this space. We're committed to improving the quality of life for Medicare beneficiaries, reducing the impact of chronic diseases, and saving healthcare costs. OSA is a subset of sleep disordered breathing and is a common chronic medical condition where partial or complete collapse of the upper airway is caused by a relaxation of the muscles when patients fall asleep. When this collapse happens, it causes a fight or flight mechanism within the body that can exacerbate some chronic conditions, in the cardiopulmonary system, such as stroke, drug-resistant hypertension, and atrial fibrillation. Physicians that are board certified in sleep medicine diagnose OSA by looking at a patient's apnea-hypopnea index, or a full or partial obstruction of the airway. And mandibular repositioning devices can be used to treat patients with mild to moderate OSA that do not, as well as patients that do not tolerate PAP therapy. And one thing that we do know about PAP therapy is that getting patients compliant and using the device is very important. MRDs give patients a second chance, or sometimes a first chance if they can't tolerate therapy to begin with, to receive the therapy that they need. The way they do this is by advancing the lower jaw to prevent the pharynx and tissues from collapsing into the back of the airway. Without an MRD, the pharynx would collapse normally, but with an MRD, it's pulled out. These are FDA-cleared medical devices. It must be prescribed by a physician and is custom fitted and titrated by a qualified dentist with advanced training in dental sleep medicine. Medicare gives these dentists DMEPOS supplier numbers so that they are able to bill the Medicare system. And MRDs have been given clinical guidelines by the American Association of Sleep Medicine as well as the American Association of Dental Sleep Medicine for adults with obstructive sleep apnea who are intolerant of CPAP therapy or prefer alternative therapy. As we know, one of the largest challenges with professionals in this space is making sure that they can find the right device to fit the right patient. Diverse patient needs require a wide range of devices, and clinicians need to have the option to choose what is the best device for their patients. All of the devices on the market today that are currently have EO486 have some sort of metal component in them. And Narval is made of a polyamide polymer that's able to be biocompatible, is very durable, has a low profile, and is extremely well tolerated. There are patients out there that do have allergies to the existing metals out there, and they need an alternative therapy in order to meet their clinical needs. Additionally, there are different methods of articulation for different clinical needs. The way that some of these devices work is they actually put a lot of pressure on the temporomandibular joint when they're advancing the mandible. So there's different methods of articulation. There's hinge-based, compression-based, and traction-based. Narval is a traction-based device that actually applies pressure along the occlusal plane, which doesn't put as much pressure on that temporomandibular joint. We are in the process of conducting a large clinical study in France. There's 28 centers, 100 investigators, and 369 patients. It's evaluating the long-term efficacy and tolerance of MRDs, specifically Narval, for mild to severe OSA patients that are non-compliant with CPAP. And the findings are remarkable. With a 3 to 6 month follow-up, we see that the MRD is very effective in treating therapy. 79% of patients are successful at decreasing their AHI by 50%, and 66 patients actually get their AHI under 10. Maybe even more important is it's very well tolerated. The patients that use Narval CC sleep on average about 7 hours per night, almost every day of the week. And during this trial, we found that only 8% of patients actually discontinued therapy with Narval. So let's talk about policy article A525.12. Narval currently meets the HCPCS coding description of EO486. It is an oral appliance used to reduce upper airway collapsibility. It's adjustable, custom fabricated, and yes, the dentists do the fitting and adjustments for it once a medical physician has written a script for them to do so. However, in 2012, there was a local coverage policy article that redefined EO486 with a new fixed mechanical hinge requirement that limits devices to those with metal features. In this policy article, they define a fixed mechanical hinge as a mechanical joint containing an inseparable pivot point. Interlocking flanges, tongue and groove mechanisms, hook and loop, such as the TAP device here, or such as the Easy Breathe device here, which are currently coded as EO486, but I've still been received the codes even though they don't meet this fixed mechanical hinge requirement, are currently coded. So there's some inconsistencies in the way that this policy article is being interpreted. Additionally, the Narval CC is inseparable while it's in the patient's mouth. The only way to actually titrate the device is by removing it from the patient's mouth and using separate rods that a clinician and a dentist would put in to actually make sure that the jaw is protruded enough to get a clinical effect. At the end of the day, this is limiting beneficiary access to therapy. Our ask today is to give Medicare beneficiaries access to innovative and effective MRDs by granting physicians the discretion to choose the most appropriate device for their patients. We're not asking for any more money. We just want that patients to have access to Narval CC and similar devices that have non-fixed mechanical hinges. There's two paths that I see that Medicare can accomplish this by. One is by creating a new level 2 hip PIC code for non-fixed hinge devices. The other pathway is to verify Narval CC as hip PIC code EO486. One way to do this is to modify policy article A52512 by adding the words while in the mouth, because Narval CCC is not separable while in the mouth. With that said, in summary, OSA is a medical disease. This is a medical device. The suppliers do happen to be dentists that do have DMEPOS suppliers, but this clearly fits within the medical benefit, not in the dental benefit. Patients need the options to choose a device that best meets their needs. And Narval is effective and well tolerated by patients. So we request that you give beneficiaries access to this device through one of the options that I've laid out here, or if CMS needs more time to work through some of these policies, give this a miscellaneous code E1399 until such time as they're able to reconcile the differences between the existing coding policies and coverage policies. Thank you very much. There are no 5-minute speakers, so I'll entertain any questions.
Thank you for your presentation. In the paths that you mentioned, new code for Narval, include Narval and EO486, or assign a miscellaneous code to Narval. There is another path that didn't make your list, and that would be maybe considering asking for a benefit category determination from Medicare. I just wanted to call that to your attention as another option.
Thank you very much. Appreciate it.
All right, agenda item number 3, application 17.8, request to establish a new level 2 HCPCS code to identify the willow curve. There are no speakers for this item. Are there any questions or comments? Agenda item number 4, application number 17.78, request to establish 2 new level 2 HCPCS codes to identify the Agile Life and Mobility System. Primary speaker is Mr. James Bawani.
Hello, I'm James Blaney. I'm a partner in the Healthcare and Life Sciences practice of Epstein, Becker, and Green, and I'm here today as a representative of Next Health LLC with regards to their application for 2 HCPCS codes for their Agile Life transfer and mobility system. This is a picture of the system. As you can see from the picture, it contains a number of different components. A list of these include an electric hospital bed, wheelchair, bed scale, pressure bed mattress, patient lift, conveyor sheet, docking station, and touchkey communicator. Looking at all of these individual components, there would all be considered DME. There are several determinations to that fact. When Next Health submitted its application for a new code, they were informed that a code could not be assigned because the product was capital equipment. We weren't exactly sure why it was designated as capital equipment, but we inferred, based on the criteria for DME, that CMS may have believed that the product was appropriate for facility use only and not home use. And so I'm here today to address that in addition to the written submissions that we've made. So as I mentioned, many of the all the components of the Agile Life system are DME. Simply combining all of those DME components into one system, we don't think would fundamentally change its character as DME. So we do believe that the product is DME and that moving on to a coding decision would be appropriate. One of the reasons I'm here today is I do a lot of work with the Center for Devices and Radiological Health at FDA, and we thought that there might have been some confusion with regard to the FDA clearance for the Agile Life TMS system. The clearance, and I reviewed the materials, it is not specific to facility use. The indication that FDA cleared would be appropriate for both facility or home use. And also, within the FDA decision, the product has a designation of over-the-counter. This is a common designation for hospital beds and other DME equipment, and it also reflects a legal determination by FDA that the product can be used safely by lay people. That is, you can have instructions for use which guide the use of the product, with a manual. And that itself suggests that the product is appropriate for home use. An individual, a caregiver at home, family member, or home nurse as well. But basically anyone can operate this device. And that, again, also supports its home use. In addition, we have real-life cases of home use. There have been 75 home use installations to date. In addition, I wanted to highlight a few items. In 2013, there was a demonstration project in Connecticut, which resulted in installation of 11 Agile Life systems, which resulted in transfers from institutional care to home care. The Agile Life system was key to allowing those patients to get home and be with their family and loved ones. We're also in the process, or Next Health is also in the process of becoming a preferred vendor for the Department of Veterans Affairs. And as part of this work, they recently completed a successful pilot at the Long Island Veterans Home, which itself could be considered a home environment, basically an institution where veterans would reside at later years in their life. In addition, many patients and caregivers of those 75 installed units to date have given testimonials with regards to the benefits that those products have provided to their bedridden loved ones. And just to review the criteria for durable medical equipment, again, all these criteria seem to be clearly met, with regards to withstanding repeated use, 3-year life expectancy. This is made out of metal. It's not going anywhere in 3 years. It's definitely, it serves a medical purpose. This product is for bedridden patients only, people that need help to be transferred from one location to another, they need this equipment. They need all of these pieces of the equipment as well. You need a hospital bed. You need a wheelchair. You need a commode. You need this touch screen to be able to operate it. All of this is intrinsically valued and intrinsically necessary to the use of the product. And it's all to serve the medical purpose of people that are bedridden. Again, it also wouldn't be used in the absence of an illness or an injury. And as I discussed previously, and as I discussed in the written submissions, it is appropriate for home use. It's been determined to be so by FDA, and it's been successfully used in that environment, and we have information that I just recited to support that fact. So with that in mind, assuming that we've gotten over the hurdle of this being DME and that a code could be assigned, then the next question would be, why do we need a new code? And it's because the current HCPCS codes that are available don't adequately describe the combination of all the components that we've included. There are codes, the most similar being patient transfer systems for patients above and below 300 pounds. And these are described as multi-positional patient systems with an integrated seat. But this doesn't really reflect what the AgileLife system is providing to patients. We have zero lift hands-free capabilities. In the home care setting, AgileLife is the first patient transfer system that can be operated easily by a single caregiver. It's basically a touchpad, and it can transfer the patient from the bed to the wheelchair and on their way. So again, this is a really important capability, and it comes from the integration of all the components. All these components are being integrated, and they all lead to the benefits to the patient. And it's doing more than simply just transferring a patient from point A to B. It's providing them with a better quality of life and a better level of independence that a patient transfer system description alone doesn't capture. And so that's why, because of that, because of the combination, because of the new capabilities, we're here to ask the CMS to reconsider this denial of a new code and issue one that we believe is more appropriate for the technology. And I also just wanted to mention some future innovations that NextHealth is working on with regards to the AgileLife system and their work in this area. For example, they are partnering with the Human Engineering and Research Laboratory at the University of Pittsburgh, which is led by Dr. Rory Cooper, and working on developing long-term solutions for disabled and returning veterans with physical limitations, the exact patient group that could benefit from a new coding decision for the AgileLife TMS. NextHealth also received a $1 million small business grant from NIH to conduct research with Dr. Cooper and his team on future innovations. Maybe down the road there would be a powered wheelchair, for example. Those are the types of innovations that getting new coding decisions like the one we're requesting would help encourage, because it will provide for an appropriate coding and then hopefully an appropriate coverage for those new technologies. And so I just wanted to highlight some of that work because I think that's important to the overall context. Again, the proposed codes we have, there are two codes. They differ in terms of weight capacity, similar to the existing patient transfer codes. But again, the way it's written, it captures essentially all the components that are being combined and that zero lift patient transfer ability that the single user can actually use the product. That's key to the value of this device. And so we believe these descriptions would accurately reflect the combination of the DME that's being included in the system and also the value in terms of being a zero lift patient transfer system that any individual caregiver could use. That's all I have to share today. Are there any questions that I can answer? I'm sorry, there's a 5-minute speaker. Oh.
Yes. Mr. Raymond, you're not going to speak now?
Hi, thank you.
Yeah, oh, I think there was just some confusion. You weren't planning to speak. Yep. Okay, I'm sorry, are there any questions?
Yeah, hi. I just had a couple questions. How is the Agile lift different than a Hoya lift? Because my understanding is that one person can't operate that. And can you expound just a little bit on how the device improves quality of life?
Okay. Actually, could I refer to Raymond for that question? Is that all right? I'm sorry, Ray, would you mind coming up and speak to that point? Ray's with Next Health and is probably the most appropriate to answer those questions.
I think so. Good morning, everyone, and thank you for the opportunity to speak with you and to respond to the questions. So let me take the first one that deals with the Hoya lift. The Hoya lift is a device that was designed to move, when it was originally came to be, maybe an engine out of a car that would move something from point A to point B. Over time, that was then taken to the medical world, all right, in healthcare, and to help move an individual. We're different in many ways, but let me point out a few in particular. The Agile Life device that James described is not a device that lifts someone. It's a device that transitions someone smoothly from a traditional hospital bed to wheelchair. And that's a very important message there, because the individual is not being tugged at. They could have a medical condition that makes them nervous, that when they're in a Hoya lift, they could tend to rock. There have been instances where during that rocking, they have fallen out of a Hoya lift, while this device smoothly transitions them from the bed to the chair or from the chair to the bed. Another key difference is the fact that when they are transitioned from the bed to the chair has a built-in commode capability. So you do not have a secondary transfer then, where the individual then has to be moved when they were transferred via the Hoya lift to a chair where they may reside for a while, but then it's time to toilet. And if they have to toilet, then there's a move with multiple caregivers to take them from that seat and get them into a toilet, which by nature is a very dangerous situation as well. You're in a confined area. There have been many accidents that have occurred. Another point being that the skin shearing that can go on when you're moving an individual that is in a bed via Hoya lift, where you're tugging at them, you could be incurring additional skin shear that could develop into a pressure ulcer. That pressure ulcer could then cause a readmission where the individual is back into an institution for a significant cost amount. All right. Last year when I testified up in Hartford, someone asked me the same question. I said, a key difference is the fact that an individual that's moved via Hoya lift tends to be moved from point A to point B, and then they reside at point B for a significant period of time. During that time, they may be in a diaper. And unfortunately, another situation could occur that could develop into a pressure ulcer. What we've found with the 75 plus installations in the home environment is that individuals are moved more frequently because the time that it takes to move an individual is reduced from a period of 20 to 30 minutes down to a 2-minute transition with a single caregiver. So an individual that may have been taken out of bed and moved with 2 or 3 caregivers to their lazy boy chair for the day, all right, is now being able to move out of bed in the morning, have breakfast, then move back to bed in a more frequent manner. So there's enhanced mobility that can significantly improve other medical conditions that can be, that the individual unfortunately has. Hopefully I gave a few examples there.
I have a 2-part question. One is, Mr. Blaney, you mentioned that 75 units have been in homes to date. This product was cleared for marketing by the FDA in 1997. So I'm just curious of those 75, how many are in use now in patients' homes? And of those, are any of them operated by the patient as opposed to by the caregiver?
Do you want to take that?
So the initial clearing took place during that time frame. There was initial pilots that have been done over a period of time with modifications made to the device, but the majority of the activity has taken place from mid-2013 and on, all right? The majority of the installations to date have been operated by a single caregiver in a home. James made reference to a project that we did in the state of Connecticut. The project that he referred to falls under the category of Money Follows the Person, which is a federal program, which was designed by President Bush while he was in Texas. He brought it to the White House, and the essence of that project is to take individuals from institutions and put them back into a community-based living operation. We successfully, under a pilot program with the state, moved 11 individuals to the home environment without a readmission for any reason. High levels of customer satisfaction and safety, and the project was reviewed by the University of Connecticut as the third-party participant. All right. Today, it's a moving number as a result of the models that we have where individuals could purchase the device, or in fact, they could rent the device on a monthly basis. So for any given time on a monthly basis, we could easily have from 15 to 20 devices in the field, as well as the devices that have been sold. We've seen situations on the purchase side where individuals have seen such value that with their economic means, they've purchased multiple devices to have them in multiple homes so that they find that the individual can easily be moved if they're in Florida for 4 or 5 months during the year, and then if they come back up to the Northeast or other parts of the country. Any additional questions?
Okay.
Again, thank you for the opportunity.
Yes. Thank you.
Agenda item number 5, application 17.86, request to establish a new level 2 HCPCS code to identify the Mini-Med 670G. Primary speaker is Dr. Francine Kaufman.
Good morning, and thank you for this opportunity to speak today. I am the Chief Medical Officer at Medtronic Diabetes, and as such, I am an employee and also a shareholder at Medtronic. We are here to request a new DME code, namely Automated Basal Insulin Delivery System, external insulin, which was denied on the basis that a national program operating need was not identified, and this is concerning the Mini-Med 670G system. We disagree and believe there is an operating need for a new code, and we shall show during this presentation the reasons why. I do want to state that the FDA has categorized this product as an artificial pancreas device system, single hormonal control, and that's synonymous with automated basal insulin delivery system, external insulin, and it's often also referred to as a hybrid closed-loop system. The 670G system received FDA approval in September of 2016 for type 1 diabetes patients over the age of 14, and of course with no upper age limit. You can see on the schemata that the 670G system consists of a new insulin pump, pump supplies, a CGM sensor, and its transmitter. The device, every 5 minutes, automatically adjusts the delivery of basal insulin based on sensor glucose readings, which means the pump will automatically suspend the delivery of insulin if the glucose levels are rapidly falling, or it will provide extra insulin if the glucose levels are rising. And this is done without user intervention and without the need for a fingerstick glucose measurement. This slide is to illustrate why this is necessary in the type 1 patient market at this point in time. This is data from the United States, was reported in 2013, and it's from a large cohort that is made up of 67 clinics across the country and looking at over 26,000 patients with type 1 diabetes. In the first larger graph, you can see that the A1C, which is a measure of glucose control, with the goal to be below 7 in the adult population, is not achieved for the vast majority of patients with type 1 diabetes, including those in the Medicare age range. Not only do they have failure to achieve this target, which is associated with the long-term complications of diabetes. The higher the A1C level, the greater the risk that the long-term complications, such as loss of kidney function, the need for amputation or blindness, may occur. In addition, in the smaller graphs, the short-term complications of diabetes in excess of severe hypoglycemia or immediate hyperglycemia leading to the serious condition called diabetic ketoacidosis also occur at very high rates still in the type 1 population. The point of the 670G technology is to handle these ups and downs of the glucose levels to prevent frequent low and high blood sugar events, to reduce the short-term complications of severe hypoglycemia that can lead to seizures and loss of consciousness, and to reduce the episodes of severe hyperglycemia that can lead to ketoacidosis. So if we focus on these long-term complications, we do believe that the 670G technology will mitigate this problem. And let me show you why. This is a slide. The top shows the sensor glucose readings. The colored bar is the target range. And as the sensor glucose readings go up and down, which occurs with activity, with the ingestion of meals, during sleep, during stress, at the bottom you can see that now the 670G automatically adjusts basal insulin delivery. There's no device that has done this in the past. This is the first device on the market capable of automatically, through control algorithms and mathematics in the pump itself, to be able to automatically adjust basal insulin delivery without the need for the patient to do finger sticks or to intervene. This is done automatically. I do want to say that that footer that's very hard to read is to say that the pump is not approved for patients 7 years of age or younger. We do believe that this improved control, again, will mitigate the long and short-term complications of diabetes by improving glucose control. Further evidence that was done in our pivotal trial that allowed for the FDA to approve the product showed a significant reduction in this A1C level from a mean of 7.4 in 124 patients who used the device for 3 months. That was their baseline A1C, and at the end of the study, it had reduced to 6.9, which is below the target of 7. During this time period, there were no severe episodes of hypoglycemia or diabetic ketoacidosis. And in the bars in the middle, the gray shows the greater variability of the glucose when just a regular insulin pump and sensor are used, and the pink shows a reduction of this glycemic variability, those highs and lows of the glucose value, when the automatic basal insulin delivery system is used. And at the bottom are tables showing that there's an increased time in the target range of 71 to 180 milligrams per deciliter for the glucose value, both day and night, as well as nighttime only. And this is achieved by reducing high glucose values as well as low glucose values. And this is to show a single patient experience with the device in 1 week, 4 nights from a single patient. And the tracings at the top are the sensor glucose values. The pink line is what the system is adjusting the glucose value to, of 120 milligrams per deciliter. And at the bottom of each one of these, you see this variability of basal insulin delivery done by the device itself with no input from the patient, done while they're sleeping, so that the glucose values they experience are more controlled with less high and less low glucose values. And again, this is to show you the experience that we saw from the patient. So when we look at manual mode, which just means regular pump and sensor use, compared to auto mode with a 670G system using the automatic delivery of basal insulin, again, we see improvement in the time in range as well as hypo and hyperglycemia. So this data, we have now launched this product. We are in the midst of having 31,000 patients who have bought the system. We're busy right now educating providers and patients on how to use the system, and by the end of the summer, early fall, we will have that first group on the device, and then we'll be continuing to add patients with the estimation that there may be tens of thousands of more patients who will want to use the system. Again, this glucose control leads to the reduction of the long-term complications of diabetes, particularly cardiovascular disease, as well as the need for amputation, the introduction of kidney failure, or blindness. So we do believe that we have a system, a closed-loop system that allows for the automatic delivery of basal insulin that will improve patients' outcomes, addressing their improvement of their A1C value, a measure of glucose control, with a reduction of low blood sugar and glycemic variability. This all translates into a better future for our patients. We use a variety of names to describe the system: closed loop, auto mode, and also the auto basal delivery of insulin. We do believe that this is a new system and that it will bring much promise to patients with type 1 diabetes. So in conclusion, we do believe that its 670G system meets all the necessary Tier 1 and Tier 2 criteria for a new code. We do feel that this new code is required, and that we hope you will realize that this is a significant breakthrough in the treatment of type 1 diabetes. Thank you very much. Yes, okay.
Mr. Bruce Bode. No, right there in the front.
Thank you. My name is Bruce Bode. I'm a diabetes specialist from Atlanta, Georgia. I have been involved in pump development since the late 1970s. Been also in development in CGM devices since the mid 1990s. My disclosures are I do receive research and grant support from all the sensor makers as well as Medtronic. I've also received consulting fees and speaker fees from Medtronic. I have been part of these pivotal trials known as the 670 hybrid closed loop. I was part of the pivotal trial for ages 14 to up to 75, as well as we have also completed the pediatric from age 7 to 13. This device, as Fran mentioned, it automatically always uses a glucose sensor. You got to calibrate the sensor with a specific meter, but you're always trying to get to a glucose of 120, and it's based on the sensor glucose. So if you're ever above 120, every 5 minutes it's bringing you down to 120. If you're below 120, you're bringing it up to 120. The benefit here is it lessens it decreases the amount of hypoglycemia dramatically. We had 0 hypoglycemia in this pivotal trial of 124 patients. We got to an average A1C of 6.9. In my whole clinical development of studies, we have never gotten an A1C in type 1s under 7 without severe hypo. So this system is actually, in our minds, in any patient that's been on it, is a game changer because it creates people to be in a very stable glucose range, typically 70 to 180, without having significant lows or significant highs. Patients still have to calibrate the system. They have to wear a sensor. They have to wear the pump. They have to follow what patients, they have to follow the instructions on what to do. But from a patient standpoint, it allows people much improved control. And unfortunately, people with type 1 diabetes comes from all walks of life. Some people have cognitive impairment, others don't have the ability to do math and count carbs very well. This system improves the safety. It's really improving the safety and improving the overall glucose range. In my experience, and I've treated over 20,000 type 1s in my practice, clearly a third of patients can do very well with manual pumps. They can do well and do it, but 2/3 can't. And this is a game changer. And when we look back, this is a pivotal time in diabetes from the discovery of insulin. This is a very powerful device that is very safe, and fortunately, it gets people in a safe range. So I thank you for your time.
Are there any questions?
Yeah, I have one. So you didn't address this directly, but you sort of implied it because of the way that it manages to control the range. Can you speak specifically to the impact on the number of additional bolus injections that people use when they use this system compared to standard pumps? Because we know that with the standard pumps, there's a lot of alarming going on and blood glucose monitor checking and adjusting of bolus doses and so on. And so you sort of implied that because it keeps it in range better, that there may be less of those, but I'm just curious about some specifics.
They still need to dose for their food, so they use the bolus calculator inside the pump. They determine how many carbohydrates they're going to eat, or often some of the other components of their food, put that into the pump, and then it will automatically give them the bolus for their meal. They may also have to take a correction which is calculated by the algorithm, and then they can accept that if they want to, or not take an additional correction dose of insulin as a bolus. Most of the time they will take it. But what the difference is here is, we have given a relatively flat amount of insulin for basal insulin delivery, either by injection with one basal dose or by standard pump therapy at this point, where maybe there's a few adjustments throughout the 24-hour period, but they're not significant for the most part. And what we're seeing is that it's not the same day to day, that from midnight to 3 in the morning, you may need a lot of insulin one night, you may need none the next night. And this is the only system that can adjust by the sensor glucose data to deliver insulin according to what the glucose is, to keep it in a more narrow range.
Yeah, so there are alerts. There's a lot of safety alerts in this built in to make sure it's operating appropriately. So the system will ask for a blood glucose if it's uncertain that the sensor's not operating, so they put that in to make sure it's safe. It will also tell them exactly what to do if they're going low. It'll have an alert and say, you need to check your blood sugar. Is that true? You need to consume carbs. If your glucose is high and not coming down, it will alert you saying you need to troubleshoot your site. Is your sensor working? So it has all these safeties in it. So you still have to pay attention. It's not, you can't just put it on and not do anything. But the benefit to the patient is that now they're in a safe range, and if they follow what it says to do, you should never have a low sugar, we hope. and you should be in much better range. We got down to 6.8 in adults, 7.1 in adolescents, which is unheard of.
I'm Dr. Bob Hoover. I'm one of the DME-MAC medical directors. I mean, your presentation, you talked about not having to do finger sticks, and I just want to be clear, that's not correct. I mean, you still have to do finger stick blood sugars, not necessarily for the basal rates because you're using a sensor, but for your bolus injections at meals. And reading about the literature, it talks about you have to input the carbs, and it does calculations for you, tells you how much in your bolus meal injections you have to do. What happens with this device if you don't want to monkey with it on the meals, that you just want to allow the basal rates to go and independently, maybe you don't count carbs, you use another method for figuring out how much you want to inject, and you're going to do that independently. Will it still do the calculations on, will the algorithm work, I guess is what I'm trying to say, or do I have to specifically put in, I used 4 units of a short acting at this meal at these points in time?
So you wouldn't be taking shots in addition. So there's no short acting insulin. It's all rapid acting insulin in the pump itself. So you likely could not go day after day eating without taking boluses for meals. I mean, it may be able to correct if you miscalculated what you're eating, or if you perhaps missed a meal bolus here and there, but chronically it will not work. It would keep you too high because there's some constraints on the maximal amount of insulin that can deliver with these 5-minute intervals.
So, and I may not have been clear in my question. What I was questioning was the complexity of doing the carb calculation in order to get, I mean, if you've been a diabetic for 20 years, you have an idea of what your meal is, what your dose that you're going to use in your bolus injections. Do you have to input those carbs, or can you just tell it, I want to bolus 8 units? Or
no, you need to go through carbs, but you could translate that back and say if this is your typical that you take 10 units, then that you'd put in 40 grams of carbohydrate for that, or whatever the equivalent is.
And more for Dr. Bodie, in your experience in your clinic with this, does doing that kind of calculation limit the patient population? What's your typical patient in the adult or in the senior population that you see using these as type 1s?
So in our study, we opened it up to a lottery. So we did not hand pick and whoever. And what we would find is some people never counted carbs, but we would teach them how to do it in saying you have to announce your food. And let's say it was 8 units and we would do 1 unit per 10 grams, we would tell them to put in 80 grams. And if you eat less than that, put in 40 grams. If you eat more, put in 120. And we would guide them to do this because the only way you can give insulin are only 2 ways. One, by carbs, or you can prick your finger, and if your glucose is above 150, it'll do a correction down to 150 based on the sensitivity factor, which is based on the algorithm, this PID algorithm. So this system is all about safety, being in a safe zone, and this is a safe zone, but we're getting down under 7. We've never done this without hypoglycemia. And so people, we bring them in, and one of my patients initially wore it in the pivotal trial, and he comes back for follow-up, and he doesn't have the sensor on. He says, my sugar's running high. And I said, well, where's your sensor? I said, I thought this would automatically learn. If I just wore the sensor one time, it'll learn. I said, well, no, you need to wear it. So everybody comes from different backgrounds. You work with him, you coach him. And now he's back wearing the sensor, and he says, hey, every time I wear the sensor, the system works. I said, but he didn't understand the sensor drove. He just didn't understand it. He thought it was magic in the pump. But that's how people are. You come from all walks of life, including elderly. As you know, elderly have a high rate of hypoglycemia because of hypoglycemia unawareness. Some people have had diabetes 40, 50 years. Fortunately, people are living longer now with type 1 diabetes. Hopefully, you can live into adulthood in retirement. But these people have much hypoglycemic unawareness. They have cognitive impairment. This has to get covered. It has to. Fortunately, our wealthy patients will just pay for it. They'll pay for it, or the families pay for it. But that's not right for our community. You should allow it to everyone. If they need it, they should have this device.
A comment you made, and if I missed it, I apologize, but you mentioned fewer amputations and fewer cardiovascular complications, and the data just had the difference in the delta of 0.4 in the hemoglobin A1C, and I'm wondering, do you have actual data in terms of what % of fewer amputations and what % of fewer CKD and other cardiovascular complications?
So as at this time, we don't have data on that. The trial that was done, this pivotal trial, was a safety trial to get it approved, because everything FDA is about safety. You want to make sure you do no harm. And unfortunately, it did no harm, but it had good. I think you can interpret in long-term pivotal trials, which Medtronic is undertaking, very large 1,000-patient trials that will hopefully get data that we can look at A1C and time in range and correlate that to long-term complications.
Yeah, I think we could use the data from the DCCT trial that talks about if you reduce the A1C, and of course now for the first time we've actually gotten the cohort, the mean value, into the target range of below 7. So for even a half, so it was actually 0.5% reduction, which is felt to be significant in the world of diabetes treatments, that you would have a reduction in the percentage of those with all the long-term complications. So you could look at that curve from the DCCT and then use the core model which has been developed and show that you likely will reduce the long-term complication rate because of the reduction of 0.5%.
Great. No, I just asked because in the cardiology world, we now have many trials where we change HDLs and LDLs by magnitudes of 100%, but the outcomes don't change.
Mm-hmm. Well, thank you.
Thank you.
At this time, we'll take a brief coffee break. Please return by 10:50.
I need a hug.
If everyone could begin to settle down so that we can start. Okay, so before we proceed with the meeting, I just want to let everyone know it would be nice if you could just keep your conversation to a minimum. There appears to be a little feedback when folks are talking, so we just want to be respectful of our presenters. Agenda item number 6, application 17.115. There are 2 requests here. So the first is 115, and it is a request to establish a new level 2 HCPCS code to identify contour next test strips. And then the second is application 17.116, which is a request to establish a new level 2 HCPCS code to identify the contour next link 2.4 blood glucose monitoring system. And our primary speaker is Mr. Robert Shum.
Good morning, and thank you for considering our application for new reimbursement codes for blood glucose monitoring associated specifically with artificial pancreas device systems like the one we've just seen from Medtronic today. My name is Robert Shum. I'm the Managing Director of Essentia Diabetes Care, and I am responsible for the U.S. operations and therefore a full-time employee of the company. Now, I realize that granting of new reimbursement codes is not done lightly and is only done when there's a specific and compelling need that exists. I do believe this is one of those cases and appreciate the opportunity to explain the gap that exists specifically among the type 1 diabetes patients who are prescribed such artificial pancreas products by their physician. Our application is for 2 new codes. One for the blood glucose meter associated with the artificial pancreas system, that's the Contour Next Link 2.4, and the second is for the test strips needed to use the system on an ongoing basis for insulin dosing, bolus dosing, and for CGM calibration. The FDA requires 4 calibrations per day in order to obtain the accuracy of that system. Importantly, the strips are a key area here because that's where much of the technology lies. I know it seems like it's a lot in the meter, but those strips are very much where the accuracy technology lies. There are a few key reasons why the existing reimbursement codes for blood glucose monitoring do not provide patients the needed access for the artificial pancreas system, which I'll talk about here. First, the existing codes do not adequately differentiate between Class 3 PMA-approved products reviewed under more stringent criteria as part of the artificial pancreas system used by type 1 patients with diabetes, and the lower risk Class 2 products cleared under a 510K that are used by a broad range of people with diabetes. These highly accurate PMA-approved meters and strips are needed to support the optimal functioning of these innovative new systems. for the patients with the greatest need for that accurate therapy. And perhaps most importantly, the commoditization of older technology in the blood glucose monitoring world has led to reimbursement criteria that doesn't adequately support the management of a category with evolving diverse needs, specifically the needs for the patients among which any meter may do, and the narrower group of patients for which a high degree of performance is a necessity and key to safety. You've already heard this morning about how an artificial pancreas system, as defined by the FDA, works. Importantly, we're talking almost exclusively about, or here exclusively about, type 1 patients for whom carefully managed insulin delivery is a necessity of life. Most of the components you've heard about already, an integral component here as well is a blood glucose meter and test strips used for calibration 4 times per day and the checking of the CGM sensor as well as bolus insulin dosing. These artificial pancreas systems are classified as Class 3 medical device by the FDA, and as such, the blood glucose monitor must also fit that classification in order to be part of that system. In the box at the bottom here outlines FDA's rationale for that classification for BGM, which is fairly extraordinary. Because the accuracy of the BGMS exerts a tremendous impact on the quality of the calibration and the performance of the APDS, sponsors are encouraged to consider the use of the most accurate BGM devices that are practical for patient use. This makes very clear why the FDA required Class 3 status for this specific subsegment of products in a category that has traditionally fallen under Class 2 designation. So the Class 3 designation for BGM, or blood glucose monitors, brings with it significant additional requirements. Some of the first few are general differences between Class 2 and Class 3, showing substantial equivalence for a Class 2 device to a predicate device, as compared to having to be demonstrated specifically safe and effective for this use. Class 3 devices are used in higher risk situations, specifically those that sustain life or pose a high degree of injury or illness. The cost for applying for a Class 3 designation is substantially higher. But most importantly, for blood glucose monitoring, the requirements that need to be met with respect to accuracy, quality, and consistency are also much greater and must be demonstrated. The details are outlined in here, but essentially, while mass-marketed blood glucose monitors must obtain or currently mass-marketed products obtain somewhere between plus or minus 20% or plus or minus 15% accuracy to a lab reference in the majority of situations. The Class 3 BGM for use with an artificial pancreas system must consistently deliver plus or minus 10% accuracy. Importantly, on an ongoing basis, every manufactured lot must be subject to release testing and stability monitoring. That's in sharp contrast to generally marketed test strips, which really only require intermittent testing. And finally, any change to raw materials, manufacturing, or any change to the system at all requires pre-review. And this adds considerable cost and time burden for any change that we might do to make to improve the product or change it. In summary, the bar is just much higher for such products as fits the higher risk classification level. So why is it important that blood glucose monitoring devices in an artificial pancreas system meet these higher standards? Well, the reason is because it serves an important fail-safe to the system, which I'll speak over to in the next couple of slides. While the accuracy of CGM systems, continuous glucose monitoring systems, has improved dramatically, it is still a long way to go before it achieves the accuracy levels afforded by directly measuring blood glucose. This slide here shows the approximate relationship between the standard measure for BGM, okay, which is shown on the x-axis, which is plus or minus a margin of error to a lab reference, and the standard measure of a CGM, which is MARD, or mean absolute relative difference, shown on the y-axis. So today, a very accurate CGM device would deliver a 10% MARD, and that does not correspond to a 10% accuracy for blood glucose monitoring. In fact, that corresponds more to a plus or minus 25% to a lab reference, as would be seen in a blood glucose, actually blood glucose measured monitor. This level of plus or minus 25% is kind of reflective of levels that we've seen back in the 90s, right? So it's evolving technology, getting much better, but still not as accurate as a finger stick. For comparison, moving in a little bit, the international standards and FDA proposed new standards that have not yet taken effect require 15%, but 10% would be what's required in this artificial pancreas system, which would correspond to about a 4% MARD. So much more accurate than a CGM device would be standing on its own. This next slide just helps to visualize the differences in BGM accuracy we just talked about. We see the difference between a device that would fall just beyond the requirements for ISO, or that plus or minus 15%, and a plus or minus 10% rating. And as you can see, those results cluster much tighter to that true, real measurement as specified as the lab reference. You might ask why I'm showing the results of a meter that falls just short of the newly proposed FDA guidelines, and the reason is because many such systems exist on the market today because they're grandfathered. In fact, the vast majority of Medicare patients today, the vast majority of the strips purchased by Medicare patients today fall into that category. So what's the relevance of this in an artificial pancreas system? The most crucial function of a blood glucose monitor in this type of a system is the calibration of the CGM sensor. The diagrams here show results of the interplay between BGM and CGM accuracies and the direct implication to clinical outcomes. This study was based on modeling, and it models the impact of different BGM accuracy levels on 3 different fixed levels of CGM accuracy on clinical outcomes. On the left, you're looking at A1C, and on the right here, we're looking at severe hypoglycemic events. Within each of these charts, the tightest cone here shows a CGM, most accurate CGM sensor with a MARD of 8, then 13%, and then a MARD of 20%. So the goal here is consistency. You want to keep the cone as narrow and as low as possible. The variable in this study is the margin of error of the blood glucose monitor used to calibrate the system. And that's what you see on the x-axis. So the more variability, or the greater the inaccuracy of the blood glucose monitor, the greater the variability you see in the outcomes associated with the CGM. In fact, the inaccuracy, this modeling here showed that the meter accuracy, or actually the inaccuracy, can produce a change of up to 0.65% percentage points of A1C when maintaining fixed CGM accuracy. So point here is that a very important factor of getting the right CGM accuracy is making sure it's well calibrated and calibrated with an accurate device. Another factor that plays to the importance of using the BGM device intended for use with the artificial pancreas system is the communication link. BGM measurement is transferred wirelessly to the pump for the purposes of the calibration and dosing, and that minimizes the human error associated with the manual entry. The integrity of this data transfer is particularly important when it comes to an automated artificial pancreas system, because these decisions can be made without user intervention. Finally, the BGM device also serves as a remote to control for insulin bolus release. About 20% of type 1 patients forget at least one time a day to give a bolus, so this it helps to facilitate that as well. So it all sounds great, but why do we need a new reimbursement code for such a product? And the issue lies in the current reimbursement dynamics for standard test strips. Driven by the DME competitive bidding program, the Medicare reimbursement price for standard blood glucose test strips has declined by 85% over the past 3 years. A 72% decline in 2014 and a further 20% in 2016. Private payer reimbursement has followed suit with dramatic decreases in reimbursement levels. Now, given these low reimbursement prices, commercial sellers have steered patients away to the lowest cost products. So even though someone might be on an artificial pancreas system, they will switch them to the product that is the lowest cost, even if they're grandfathered products not even meeting the new standards, even the most recently proposed Class 2 standards. Given the size of the Type 2 patient base in the U.S. and the need to control overall cost of diabetes and healthcare costs, this is a concerning, but it's an understandable trade-off if you're talking about the general population. However, when it comes to this narrower population, Type 1 patients who are prescribed an artificial pancreas system, this causes a significant access and a safety problem. Commercial sellers are increasingly refusing to sell the patients the test strips that accompany their artificial pancreas system because the reimbursement level is insufficient to cover those costs. Instead, they actively switch patients to other Class 2 test strips and non-linking commodity meters. As a result, these patients are not able to obtain the test strips that the FDA determined demonstrates the necessary performance of the artificial pancreas system. It increases the risk to the performance of the entire system and the risk to the patient who is using it. So because of the added burden required for much of the rigorous Class 3 designation, it's not possible for such a product to match the price of a commodity product held to much lower standards. So, just in conclusion, we respectfully request that the committee reconsider its initial recommendation, taking this information into account. We strongly believe that the new codes that are required to help support the overall APDS system. This is a new FDA category and the leading device innovation for Type 1 people with Type 1 diabetes. This is driven, again, by the significantly higher performance criteria, the cost of manufacturing, quality management required by that Class 3 device in order to be able to provide access to these patients who need to be able to use the system. From our experience, it's clear that the current coding for the category, one that groups all test strips together regardless of how FDA has approved that strip, or the degree of technological advancement is clearly insufficient to ensure that these artificial pancreas systems can be used safely and effectively as intended by the FDA. Thank you for your attention.
So I'm back again. I was invited by Essentia to come up here. I had no idea Medtronic was presenting before, so I took that time to make a comment now. My only disclosures is they Essentia paid my way up here, so I have not, I'm not consulting with them or anything, but obviously I'm very much involved in the artificial pancreas. It is crucial to get the artificial pancreas to work, you have to have a MARD of 10% or less for that sensor. The sensor is calibrated by a blood glucose meter. The blood glucose meter has to have very excellent accuracy and precision. And in the development phase, when Minimed at the time, and then Medtronic were trying to decide what to calibrate with, they knew they needed two things. They needed to have a linked meter because patients, if you manually put it in, they might say it's 129 and they put in 192. There's so many errors and about 25% errors in transposing. So you need to have an automatic system to put in, but the system meter has to be highly accurate. And the only way you can do that is using a meter that has plus or minus 10%. So before Bayer, now it's the Essentia, made that and it was able to do so. So obviously the approval of Medtronic's artificial pancreas was based on the Contour Next both meter and strip. They were able to get the Guardian 3 to have a MARD of 9.6%. Dexcom, which you'll hear later, uses Bayer in their pivotal trials to get approval of their sensors. They only use the Essentia meter. They don't use anything else. Others have, Steve Russell up at MGH had shown data at a European meeting using a one-touch ultra meter calibrating a Dexcom sensor resulted in a MARD of 18%, meaning the sensor is not accurate enough to be part of the artificial pancreas. And so from their standpoint, obviously I like inexpensive anything for my patients, but clearly you need to have an accurate strip, you need to have an accurate meter, it has to be linked. Without that, you can't result on the results we found in the pivotal trial. We were able to do this, getting to an A1C under 7 with 0 hypo, both less highs, less lows, and it's a part of the system. Right now, I have over 3,000 type 1s on pumps. And I'm doing a prior approval all the time because the insurance companies will give them anything. They don't care. They don't care about accuracy. But we, as a physician guiding people, accuracy is extremely important, extremely important. And patients will have these meters and they come in and they say, well, my Dexcom's reading 150, but I say, your A1C is 8.6. I said, what meter are you using? Oh, I got this off the shelf. And I said, this doesn't work. It's plus or minus 30% off our standard in our office. So I think it's extremely important going into this space of the artificial pancreas. You need to have an extremely precise, accurate meter. The only one that has made it right so far, plus or minus 10% with this new guidelines, is Essentia. So thank you.
So be happy to take any questions.
Just to be clear though, Dr. Cody, it's not, the accuracy of a meter is not, or the accuracy of a blood glucose reading is not just the meter itself. And in fact, when you look at the studies that have been done, and there haven't been a lot other than the one a couple of years ago from Diabetes Science and Technology, but I mean, it's recognized that it's not so much the meter, but a lot of cases it's the patient and how they apply the drop, how they, whether they squeeze their fingertip or not vigorously before they did it. I mean, there's a lot of other variables other than the meter itself that contribute to the accuracy.
Yeah, so in real life, obviously, I totally agree with you. Accuracy, if people will squeeze harder, there's multitude. And so when you do these pivotal trials to get these sensors approved, we do it in a CRC, making sure everything is done appropriately and trying to get everything done. But you're right, in real life, anything can happen.
I would just add that that burden is on us, right? We need to demonstrate that level of accuracy in the user's hands with all those kinds of errors that they might bring with it. And that's part of the requirement of the clinical trials.
Thank you.
Thank you.
Okay, so for those who may have just joined us after the break, our 5-minute speaker here was Dr. Bruce Bode. Okay, so on to agenda item number 7A, application number 17.82, a request to establish a new level 2 HCPCS code to identify the IU flow device. Primary speaker is Ms. Patty Telgener.
Good morning, and I'm using my computer due to video, so hopefully the IT gods are with me today. We tested it. All right, good morning. I am Patty Telgener. I am a Vice President of Reimbursement at Emerson Consultants. My disclosures for today, I am a consultant to Kaiser Medical, which is the manufacturer of the IU Flow. As you heard, we requested a new HCPCS code for an automatic uroflowmetry device, which would include the software and the accessories. CMS rationale for denying that request was that the product is considered an integral part of a procedure and payment would be included in that procedure. And we don't always say this, but I actually agree with CMS on that. When done in the office, it clearly would be included in that office procedure. What we're here to request is really for use in the home. And I'm going to walk you through how this device would be used in the home. So what is the IUFlow device? It is a fully automated digital bladder diary and remote uroflow meter that is used in the patient home. It has two components. It has the actual uroflow device, which you see right there, and that is actually placed under the toilet seat, and it automatically measures the volume and the flow as that patient urinates. It is then equipped with a wired connection to allow it to connect to a mobile device. The software then receives the data, and they use an algorithm to analyze the data, and that information is sent to the physician for in the home. The patient does not need to empty this device. They do not need to handle the urine, and they do not need to manually input or measure their urine. So when would physicians prescribe the IUFlow for use in the home? It would be for patients with OAB, overactive bladder, BPH, benign prostate hypertrophy, and nocturia. Any time that they need to have that patient measure their urine over consecutive days and make sure that it is being done accurately. So the current standards of care are bladder diaries and office-based uroflowmetry. But that's because there really hasn't been an accurate way to do this in the home. Current methods for measuring frequency and volume of urine have been subjective and frankly not very accurate. And if the uroflowmetry needed to be done in the office, the patient would need to come to the office. You hope they came with a full bladder, and it is a one-time measurement. So what is wrong today with the current bladder diaries? One, their usefulness is very limited. There is a very low compliance. So a patient gets up in the middle of the night and they go into the bathroom. They first have to make sure that they have their cup there that they're going to measure. They have to have the sense to then mark it, true volume, the time, how long it took them to void. All of that would be marked in a manual diary. Very low accuracy. Studies have shown that it's about 48% error rate with manual bladder diaries. Compared to, really with the automated, is around 100%. There's also a lot of concerns with the hygiene of those current bladder diaries and touching the urine and emptying that. This data can be sent directly to the healthcare provider. So when they go into the office, if they need to, that physician already has that data. The IUFlow does measure more than just volume. It measures the flow rate, the flow time. It can measure the Qmax. It can measure much more than just the volume. From a clinical efficacy, there are studies out there, not only in patient satisfaction, but truly demonstrating strong repeatability and accuracy. These tests can be used for diagnostic testing for overactive bladder or other indications, but also to determine if that patient needs to move on for further interventions such as sacral nerve stim or other interventions for bladder disorders. So there are HCPCS codes currently for urinal for male, so it's a male urinal jug. There's also one for the female metal cup. Obviously, neither of those codes would be descriptive for this automated urodynamic device, and we are here to really request reconsideration, again, for use in the home. If it is done in a physician's office as part of an overall procedure, there would not be the intent to bill this device separately. I don't believe we have a 5-minute speaker. So lots of fun topics on urine and voiding and all of that. Any questions that I can answer?
Hi, Patty.
Yes.
Is there any mechanism for inputting, like if they go to their daughter's house or a restaurant or something?
Good question. There very much is. And they frankly want to know, to have those narratives. So how many cups of water did you drink? Or were you outside the house? Yes. Oh, sure.
Agenda item number 7B, application 17.89, request to establish 2 new level 2 HCPCS codes to identify the liftware. Again, our speaker here is Ms. Patty Telgener.
So I was wondering if I should change clothes or come up as a different speaker. There is, if you look in the agenda, they did call me Miss Patty Telgener on one and Mrs. Patty Telgener on the other, but same person. I am VP of Reimbursement at Emerson Consultants. My disclosure today with the liftware is I am a consultant to Verily Life Science, which is actually kind of exciting. It's actually part of a very large company that we are all very familiar with, which is Google. Our request was for 2 new HCPCS codes for movement stabilizing adaptive utensils. These are not your standard utensils. We requested a code for the starter kit, which I'll walk you through, and then also for additional attachments, such as a soup spoon, regular spoon, or fork. CMS rationale for denying the code was clearly stated as no national program operating need. I would like to discuss today that there is a national operating need. There have actually been over 30,000 of these liftware devices already sold. 1,500 of those units have been to the VA system. We have over 1,000 units that have been purchased by various patient advocacy groups, such as the Huntington Disease, CP. We have school systems that are purchasing it. Kaiser is now incorporating them into their movement disorder program. There are also Medicaid and commercial payers that do offer coverage for DME. Blue Cross Blue Shield of North Carolina specifically states mobility and positioning equipment is covered when medically necessary, and this would be where the liftware technology would fit. This truly is a life-altering device for patients with tremor, either from Parkinson's or from essential tremor, or upper extremity disability, such as spinal cord injury, CP. And it does allow them to actually eat by themselves without assistance. The technology will prevent the shaking and the limited mobility, which currently makes it almost impossible for them to eat. And I have just some quick videos that will show you that. By stabilizing and providing motion control, this device can actually allow that patient to eat independently. There are really 2 different products. One is called the Liftware Steady, and that's on the left. That assists with the hand trimmer. The Liftware Level assists with the limited hand and arm mobility, and it keeps it stable. And I'm going to walk you through both of them. The technology, per se, it's not a medication. It doesn't control the tremor or the shaking, but it does control the utensil and it allows that utensil to remain stable. There are sensors. I know, you thought it was just a utensil. There's actually a sensor in that base that detects hand motions. There's a microprocessor that can actually distinguish between intended movement and unintended. And then there's motors that actually change how that device works. This actually product was initially developed by a fund and a grant by NIH. And it was then purchased by Google and is now part of what they call Verily Life Sciences. So I'm going to push my IT luck again today, and I don't like to do that in CMS, but I'm going to, because there's actually, I think you really need to see how this device can work. So this is actually a patient with essential tremor, which you will see with his regular spoon, it really is impossible to eat. You have it with the liftware, and it actually can steady the spoon and allow him to actually get that food to their mouth. Okay, I'm going to show you one more slide. One more video, I should say. And this is actually for patients that would have spinal cord injury or movement disorders. You notice a little different format. We actually have the product. We'll be able to just show it to you in our 5-minute presentation. But again, it helps level it and make it steady so that food can actually get to that patient's mouth. And thank you, John, for the IT. So that actually worked great. So from a clinical perspective, frankly, the evidence is pretty straightforward. The evidence has been based on functionality and allowing patients to be more independent and to be able to keep their independence, keep their pride, and be able to eat at a restaurant or at home or at school. Many times it will prevent a caregiver from having to feed a child with CP. Rationale, again, for denying the new codes was lack of national operating need. I will come back to say that there really is a national operating need. Over 30,000 devices have been sold. Those are considered the starter kit. There has been an additional 25,000 additional utensils. The starter kit comes with a soup spoon. They can also then purchase a fork or a regular spoon. Both work from the same base. There are Medicaid and commercial payers offering coverage. Out of the VA systems, we have 114 different facilities that are using the liftware technology. Kaiser has recently implemented. We actually have a letter of support from them that was included today. Google in the past, as we all know, you may not even know they were in the medical device industry. They are new to that space. So in the past, they really were only cash pay or for large systems that purchased large orders. They have partnered with a DME supplier, and they will be processing claims. And moving forward, and a HCPCS code really is needed, as we all know, to make that claim processing possible. And that is the end of my presentation. We do have a 5-minute speaker.
Mr. John Redmond.
Thanks. I'm John Redmond. I'm an employee of Verily Life Sciences, who's the manufacturer of both of the liftware devices. I've worked with a lot of users of both of the devices over the years and have seen a lot of benefit toward ability to eat independently and improvements to quality of life. I want to take this opportunity to show you the devices and explain how they work and give you an opportunity to also interact with them if you'd like. So this is our original device. It's called Liftware Steady. It's for people with hand tremor due to essential tremor, Parkinson's, or other movement disorders. It's an electronic handle that has sensors that detect the shaking of the hand, a microprocessor that can distinguish whether it's tremor or regular motion, and then a utensil attachment. So I'm showing a spoon here, but we can have other things attached to it as well. And so when the hand shakes around the frequency of known human tremor, from Parkinson's or essential tremor, it's about 5 hertz, the spoon will shake less. So the end effect is that someone with a hand tremor will spill less and be able to feed themselves more independently. So I'm just going to pass this to the panel. We had a lot of users try that device and find out that it didn't work for them because they had some other things, other movement disorders besides hand tremor. So cerebral palsy or spinal cord injury, where the issue is limited hand and arm mobility. So we have another device for them. It has a similar system of sensors, microprocessor, and motors to detect the motion or the orientation of the hand in this case, and to keep the spoon level so that someone can feed themselves. All right, and that's it for today, unless anyone has any questions.
Yes.
You mentioned that the parent company has partnered with a DME supplier to submit claims. Who is their DME partner?
And I don't know if John's going to know that. I can get that for you. I know there was actually a couple that they're into contracts with. Because I think I know it, but I want to be very sure. So I will follow that up with the actual name. I know they have a couple.
Yeah, I'm out of the loop on
Yeah.
that.
Thank you very much. I promise I'm not up here for a third one. So.
Thank you.
Agenda item number 8, request to establish 2 new level 2 HCPCS codes to identify the sustained acoustic medicine, also known as SAM, the SAM Sport, and the SAM Professional. There are no speakers for this item. Are there any questions or concerns? Agenda item number 9, attachment 17.94, request to establish a new level 2 HCPCS code to identify the Walk Joy. Primary speaker is Mr. Blaney Tomlinson.
Hi, I'm Blaney Tomlinson. Nice to see you guys again. Saw you last year. Thank you for having us out. We had applied for a new HCPCS code because we're a new technology that is FDA cleared to help reduce falls for patients with peripheral neuropathy, and now also includes Parkinson's and MS. However, there isn't a code that would cover such a device right now. And so when we first made the request, it was denied, saying it was part of a procedure. And so I guess the most important thing for today is that I'm here to ask, what would that procedure be? We've worked with a number of physicians that have sold the unit to the patients, and actually have some support, a letter that we have with us from a physician that is 100% supportive and has seen how it's helped his patients that use the device, but we're curious of what this procedure would be. And this just repeats the slide, because the way that the device works, although under FDA it was classified under 882-5050 as a quote-unquote biofeedback device, I think there might be some mistake that because it's considered or was classified under FDA as a biofeedback device, therefore it's part of a procedure or is a procedure. But that is not how the device is used. It's not a treatment. It's not used in therapy. It's actually sold to the patient, provided to the patient to wear whenever they want to ambulate. It's like a pair of reading glasses. As soon as they take it off, their proprioception is lost. When they put the device on, that restores their proprioception. And the interesting thing, I find it interesting, we're talking about all the diabetic pumps and strips. Most of our patients, a lot of the 20 million, 30 million people that have peripheral neuropathy, a large majority of them, a third of them, are diabetics, type 1s and type 2s. And then we have a large population, about 10 million, that are chemotherapy-induced peripheral neuropathy. And then we're seeing a huge increase in the idiopathic. And I don't know if it's environmental or what, physicians don't know. It's idiopathic. However, any patient that has peripheral neuropathy, they're unstable on their feet. They have no proprioception. And so what this device does, it straps on the tibia crest, and it has linear actuators in it, assisted by an accelerometer that measures their gait swing, their tibia swing. So right upon heel strike, whether it's a normal heel strike or just the typical PN shuffle, walking on the balls of their feet, as soon as that foot strikes the ground, it vibrates. That's hence the biofeedback rating by FDA. It vibrates and tells the brain immediately where that foot is in space. It closes the motory sensor feedback loop. And in that moment, it restores their proprioception. And we've seen people go from wheelchairs that could not self-ambulate, people in scooters that are now ambulating. And as you know, somebody with diabetes who's sitting in a wheelchair or uses a scooter to not ambulate, that cascade of events continues at a much more rapid rate. So this gets people up, active, ambulating. We had people that wouldn't travel anymore because they were dependent on a walker. And now they're able to visit, travel with their family, and they're not dependent on the walker. So like I said, the big question is, if it's part of a procedure, we'd like to know what that procedure is. So then it could be applied in some way. We'd have to change our business model, but at least it would give access to these patients if it could be reimbursed of some sort through a procedure, but we don't know what procedure that would be, or a new code, because there is currently not a code that it would fall under for this type of technology. And as you can see, the beneficiaries, we had, through the Foundation for Peripheral Neuropathy, we sent a mailer out to their members. And we had, over the last 3 months, we had about 150 patients that could benefit to use the device or to try the device. And they couldn't even try the device because they knew it wasn't reimbursed. So they didn't even try, knowing that it could help them. After seeing it, it had helped some of their friends that had been able to purchase it. The people with expendable income are more than willing and happy to pay for the device. So to date, it's all been sold by cash. Or we've had the adult children of a parent that has neuropathy, and they've purchased it for them after their 10-day free trial. So that's the big question. And falls are a significant cost to all of us, and they're deadly, especially in the elderly. 75 years and up, a fall, average lifespan post-fall at 75 is about, I think, at the last report I saw was about 16 months. So if we can reduce falls, even for an extended period of time with one patient, we're helping to reduce the overall cost to all of us. And so that's the big question for me before I leave, is just if it's part of a procedure, could you please let us know what that procedure would be? And if not, we would ask that it be either given a new code or be allowed to use the miscellaneous code, because there is a significant need for this device on the market. So we do have are there any questions or? Yeah, we do have a 5-minute speaker, if it's appropriate.
Ms. Deb Wells.
Hello, good morning again. I'm Deb Wells, and I am a consultant for Walkjoy in assisting them with the CMS application that they have refiled this year. And we do respectfully disagree with the decision, the preliminary decision of the work group, and hope that we would be able to have some interaction with you and maybe answer some questions about how it is that you came to the preliminary decision that it should be part of a procedure when it's a piece of durable medical equipment. The physician writes a script, the patient fills the script through a DME supplier, just like many other pieces of durable medical equipment that we know are available to the Medicare beneficiaries. So again, I think we've established the needs, the indications for use for this device are for peripheral neuropathy, MS, and Parkinson's. So there's a huge number of patients that would benefit by being able to ambulate with this device. It's not used in the physician's office. It's not used as part of any procedure. It's used when they want to ambulate. So again, as Blaine has indicated, if we could have some either questions about how you came to the decision that it's part of a procedure, the physicians that have written the orders for these patients have provided supporting letters from the Hoag Clinic, which I think you've received it by email, and the physicians are perplexed as well as to what procedure this would be part of. Anybody? So is this a situation where you would be able to provide us with some justification, or where do we go with this? If it is part of a procedure, how would we know what procedure code that would be? Okay, so those are comments. We do disagree respectfully with the decision, and we would hope that we would have either a new code assigned or be able to use the miscellaneous code. Thank you.
So, I forgot to say I am Blaine, CEO, and I do have an financial interest in the success of the company. So are there any questions? Thank you.
Agenda item number 10, application number 17.109, request to establish 2 new level 2 HCPCS codes to identify the Kangaroo E-Pump enteral feeding pump and enteral feeding sets, and the Kangaroo Joey enteral feed and flush pump and enteral feeding sets. Our primary speaker is Mr. William Nadeau.
Good morning. My name is Bill Nadeau. I'm the Medical Affairs Program Manager for Medtronic's Nutritional Insufficiency business. With me here today is Mike Dorsey from our Research and Development team based in Hazelwood, Missouri. And we're very pleased to be here to present this application. The disclosures that we have are that we're both employees of Medtronic. As I mentioned, we are very pleased to be here to discuss the preliminary recommendations of the CMS HCPCS work group for our application. We believe that these recommendations respectfully do not accurately address the requests for new HCPCS codes for both the Kangaroo E-Pump and Joey Pump, as well as their respective enteral feeding sets. The current HCPCS codes B9002 and B4035, as shown here, do not accurately describe, number one, the unique technological features of both the Kangaroo E-Pump as well as the Kangaroo Joey Pump. Number two, their unique and respective enteral feeding sets. And number 3, the fact that both of these pumps, as well as their feeding sets, are designed for use in the institutional as well as the home care setting. So respectfully, we request that the panel establish 2 new B codes, one for an enteral nutrition infusion pump that delivers nutrition, hydration, and flushing, and a second for the respective enteral feeding supply sets that also deliver the nutrition, hydration, and flushing. Both the Kangaroo E pump, shown at the top of the screen, as well as the Joey pump at the bottom, deliver both continuous or intermittent nutrition, as well as programmable water flushes. From a clinical perspective, water flushes are very important to prevent tube clogs, as well as to maintain a patient's hydration status. The Joey pump, as I mentioned at the bottom of the screen, was developed specifically for the home care setting. It's smaller, more lightweight, and it works better in the home setting. It also has an extended battery life for use in home care to enable travel and ensure a reliable power system when one is not available. And finally, it was also developed with backpacks and other accessories to support the home care patients. The use of automated feed and flush systems reduces the number of steps that are required to comply with clinical guidelines. In addition, these systems reduce the number of interconnects needed, thereby reducing the risk of a wrong route connection. An automated feed and flush system requires 2 parts. First, a feed and flush set, as well as, of course, the automated feed and flush pump. Feed and flush sets are uniquely and technologically different from feed-only sets because they have, 1, a flushing and hydration bag and tubing, which are required, as well as number 2, a unique valve that works in conjunction with this automated feed and flush pump, which now enables switching between nutrition and water infusion. To activate the valve in the feed and flush set, a complex mechanism is required, including a gearbox design, which is capable of operating the valve, additional sensors and circuitry to monitor the valve gearbox, and software to interact with the sensors and circuitry to control the infusion. The user interface is also more complex to allow for the automation of not only the nutrition, but also the flushing and hydration volumes, as well as the time interval. So I provided a review of our pump and feeding set technologies and how they are unique, as well as how these products are designed for both the institutional as well as the home care and ambulatory settings. So I'd now like to review the critical role that water plays for enteral fed patients, as well as the practice recommendations for the use of automated water flushing in this patient population. Enteral fed patients are faced with many clinical challenges. Around the delivery of water, there are 2 that are unique and present themselves, the first being clogged feeding tubes. There's a multitude of etiologies for clogged feeding tubes in the enteral fed patient, including the lack of provision of water flushes, as well as others listed here on the slide. And this is a common occurrence, as small bore tubes may become clogged in up to 35% of enteral fed patients. The consequences of a clogged feeding tube are significant, including nutrition and hydration deficiencies, hospital readmissions, and increased costs to the healthcare system. As such, the American Society for Parenteral and Enteral Nutrition, also known as ASPEN, has created recommendations and guidelines for the provision of water for these enteral fed patients, including the frequent flushing of the tube, as well as flushing around gastric residual volume measurements, before and after medications, and they've even gone as far as to suggesting the consideration of use of an automated flush pump to prevent these clogs. The second clinical challenge facing enteral-fed patients is dehydration. Similarly, there are a multitude of etiologies for dehydration in the enteral-fed patient, including those listed here, the one most relevant being inadequate fluid intake via the oral, enteral, or IV routes. Similar to clogged feeding tubes, the consequences of dehydration in the enteral-fed patient are also significant, leading to higher total hospital costs, longer hospital lengths of stay, and increased incidences of hospital-acquired conditions. A recent analysis looked at the burden of dehydration in home enteral-fed patients and found that it was significant. 37% of enteral-fed patients in the home are readmitted each year with dehydration and/or malnutrition. The costs to Medicare are significant for these readmissions, upwards of $129 million as reported in 2013. Aspen has also created guidelines and recommendations around the provision of water to prevent dehydration, and they've also stated to consider the use of an enteral feeding pump that has an automated flush system designed to provide this additional hydration. An analysis in 2016 looked at the compliance to enteral water flush orders using a manual syringe method and employing a feed-only pump versus using an automated feed and flush system. On the left pie chart, you can see that compliance to these flush orders using manual syringe method was only 35%. Whereby adoption of an automated feed and flush technology increased compliance statistically significantly to an 82% compliance rate. This analysis from 2017 looked at the skilled nursing facilities and looked at improving efficiencies and rehospitalizations for enteral-fed patients in this care setting. The analysis was quite large. It looked at over 550 SNFs and over 7,000 patients, with at least 60% of these patients utilizing their Part B Medicare benefits. The results here showed that automated flushing facilities had 14% lower average registered nurse staffing compared to facilities employing manual flushing practices. In addition, patients in these automated flushing skilled nursing facilities had a 3.9% statistically significant lower 30-day risk-adjusted rehospitalization rate compared to patients residing in manual flushing facilities. These findings are also significant and suggest that automated flushing may be an efficient and cost-effective means of improving 30-day rehospitalization outcomes in this patient population. In conclusion, and I don't have a slide for this, but I would like to give some anecdotal evidence. Prior to joining Medtronic, I was a clinical dietitian for both Walgreens Home Infusion and Option Care, managing over 450 enteral-fed patients. At least 60% of these patients were utilizing technologies that I've described here today. In addition, I can share with you data taken from Medtronic, which showed that in 2016, Medtronic sold 7.3 million units of this technology, of these feed and flush sets, to patients in home care, as well as patients utilizing their Part B Medicare benefits in facilities. In summary, we respectfully request that the panel establish 2 new B HCPC codes to accurately describe, number 1, the unique technological features of the technology described in this application. Number 2, their unique and respective enteral feeding sets. And number 3, the fact that both the pumps and the feeding sets are designed for use in the institutional as well as the home care settings. Thank you. I'd be happy to answer any questions.
Thank you. I was just wondering if there are any published clinical studies that you could point us to that would support your claim that patients have a significantly better clinical outcome when they use the automated flush systems?
We haven't been able to obtain that data as of yet. So today I cannot point you to any direct patient studies addressing that. However, I can point you to reference number 7, which I described, looking at skilled nursing facilities, which I've already described the data. Any additional questions?
On the slide about compliance to enteral water flush orders, why is there an 18% non-delivered for the automated?
It's a common occurrence for patients to be off the floor for tests, procedures, and other events that lead to non-delivery of both nutrition as well as the hydration. There's an amplitude of evidence around the inadequate delivery of nutrition in patients cared for in the hospital setting. And so compliance, in fact, it's interesting that compliance goals from a guidelines perspective are to achieve at least 80% of the prescription. And so this falls in line with those compliance recommendations. You're welcome. Thank you.
Agenda item number 11, attachment number 17.121, request to revise existing level 2 HCPCS code A9277. Our primary speaker is Ms. Beth Keat.
Hello. My name is Beth Kite, and in disclosure, I am Director for U.S. Government for Dexcom, so pleased to be here today. We're here today to ask for an update to an existing HCPCS code that's been around for quite a while. And it's been around for quite a while despite the fact that for many, many years, in fact up until January 12th of this year, there had been no coverage for Medicare for CGM systems. So really my focus here today is on commercial payers. So we're asking for your help today to help us accurately bill our commercial payers. A little bit about Dexcom. Dexcom is a San Diego-based company, and we were founded in 1999, and we commercialized our first products around 2006. Dexcom manufactures the G5 mobile system and the first and only CGM system approved for non-adjunctive use. And basically that means that you can rely on your Dexcom reading to adjust your insulin levels versus getting a secondary finger stick. Worldwide, Dexcom has over 200,000 patients on its products, and we're represented in about 40 countries out there. And Dexcom is the market leader in CGM. Dexcom has 3 distinct components to a system. First, there's a sensor. The patient inserts the sensor into their abdomen, and the sensor has a life of 7 days for Dexcom. The patient then snaps a transmitter into that sensor, and that transmitter is a durable medical device that is the HCPCS code we're here to talk about today. And that transmitter sends the results to a receiver that gives the patients alerts and alarms, tells them when they're going high and low, and basically gives them a glucose reading every 5 minutes. So why would a patient want to use Dexcom? If you think about self-monitoring of blood glucose, or SMBG, it's a point in time for a patient with diabetes. So if I have type 1 diabetes and I'm getting ready to drive a car, and I know 80 to 120 is within the normal range of glucoses, I would test my blood sugar and I would say, I'm 80. Great, I'm good to go. Maybe a little on the lower side, but I'm pretty good to go. With a CGM device, patients are actually able to see the speed and direction of their glucose as well as the glucose. So for those of you who don't have diabetes or are not clinicians in the room, you could look up there and pretty accurately get a picture of the fact that you shouldn't drive, right? Your glucose reading is 80. You have 2 arrows pointing down, which means you're dropping more than 3 milligrams per deciliter per minute. In about 10 minutes, you're going to be in trouble, right? So that's the value of using a CGM device. It's not just a point in time, it's speed and direction. In addition to that, if you have type 1 diabetes or if you're on insulin and you're sleeping and your blood sugar is going low, the device will wake you up with alerts and alarms. So there are, like I said, existing HCPCS codes for our products. There's a HCPCS code for the receiver, there's a HCPCS code for the sensor, and that HCPCS code has a 1 unit equals 1 day of service. And that's very impactful and effective for our commercial payers. Other speakers in the room today were from Medtronic. They are the other sensor manufacturer that's on the market now. Medtronic's sensor lasts 6 days, our sensor lasts 7 days. Because of that, we are able to accurately bill a commercial payer. So we are saying to a commercial payer, I'm only billing you for 6 days, or Medtronic is saying that, and we're saying we're billing you for 7 days. The transmitter, however, has no unit of service specified. And therein lies the challenge that we face today. Technology is advanced with transmitters. They've gotten smaller. Discreteness is important for our patients with diabetes. The smaller they get, the smaller the battery life. And therefore, there are different varying lengths of transmitters that are on the market today. And we don't have a way to accurately bill our commercial payers for those. So the problem for commercial payers now, there's 3 different transmitters on the market, each coded with the same HCPCS code. These transmitters have different durations of use from 90 days to 12 months. These transmitters have to be billed. The way we build is with the CMS 1500 form, of course, and we have to be billed using the same HCPCS code. It doesn't allow us to differentiate between products based on lifespan. For our payers, it leads to unnecessary administrative burden, confusion, and significant inconsistent pricing. So our proposed solution, add a unit of service to the A9277 descriptor, and we're asking for 1 unit equals 1 day of service. This would actually allow us to bill accurately for the amount of time that the transmitter would live for. This will bring billing for transmitters in line of that of sensors. It'll look the same. It'll also standardize the billing practice across all useful lifespans of a transmitter, both current and yet to be developed. And most importantly, we believe this is the right thing to do for commercial payers. We want to be able to bill a commercial payer for a 3-month transmitter and have that transmitter cost be less than a 12-month transmitter. The way it stands right now, it's a very difficult and manual process to be able to do that. The preliminary recommendation and the reason for the denial to our HCPCS application was that there was not an operating need identified by Medicare, Medicaid, or the private insurance sector. Non-therapeutic CGM devices are offered by many different manufacturers, including Dexcom. Sensors for CGM devices are currently coded based on the number of units that they can use. Transmitters may vary substantially in life, like I just explained to you. Some factors that supported the coding of sensors on a number of units support the coding of transmitters. Many years ago, when the HCPC codes were originally developed, it made sense to have a number of units for the sensors. There were sensors on the market with different lifespans. It was not even conceivable at that point in time that there would be varying lengths for the transmitter lives. And finally, a number of state Medicaid agencies and private payers have expressed support for this amendment to avoid the confusion. We've asked for some of them to report directly to the panel, and in addition, I want to let you know that we have multiple commercial payers who are supporting this effort. It really helps them to not have a manual process. The other reason given was for therapeutic CGMs referred to the new K code. We're thrilled that on January 12th, there was an administrator's ruling which allowed for the coverage or for the benefit category for therapeutic CGM. I'm here to ask you today to reconsider this recommendation, which referred to the new K codes. The K codes are a bundle, and the bundle is specific to a multitude of products that will support therapeutic CGM. 98% plus of commercial health plans cover CGM and CGM devices, and they have therapeutic and non-therapeutic uses in them. In fact, Medicare has asked when it's a non-therapeutic patient that we use the A codes to bill appropriately if it's for a non-covered item. So, as many before me today, we respectfully request that the committee reconsider our proposed solution. Add a unit of service to the descriptor. Our recommendation is 1 unit equals 1 day. This will bring the billing for transmitters in line with that of sensors, and it also standardizes the billing practices across all useful lifespans. As we talked about, and as public knowledge, Patty was here earlier talking about Verily. We also have a relationship with Verily. We're working on future products that will come out. There will be varying lengths of transmitters that are much more widespread than are even out there today. Our hope is that if we can get this adjustment, we won't be back here next year and the year after that continuing to ask for these adjustments. It will adjust technologies that are on the market now, as well as future technologies. So I do not have a 5-minute speaker, but I'd like to answer any questions you may have.
There we go. You said a number of Medicaid state agencies. Can you tell me how many and what level of individual at the agency is a proponent of this?
I'm sorry, I had a hard time hearing you. Can you repeat the question?
I'm sorry.
That's okay.
You mentioned that you have a number of Medicaid state agencies that are supportive of your request. Can you tell me how many and what level of staff is supportive of this?
I can, to give clarity, I meant to say, if I said it incorrectly, I'm sorry, we have a number of commercial payers. We have about 23 states currently that have coverage policy for CGM, and they do use the A code. An example of a commercial payer that recently gave their support is Highmark, and it is a VP in contracting who gave their support, and I'll share that information with the. We didn't go to specifically to Medicaid states. We went to our commercial payers, met with them on their billing systems, asked them if there was any other solution. I mean, we probably met with 15 commercial payers to see if there was another solution. We want to charge the commercial payers less, and it's a hard concept to grasp, but we want to be able to bill for the time span of the life of the transmitter. And quite frankly, there's no other way other than a manual claim system to be able to accomplish that. Any other questions? All right, thank you very much.
Agenda item number 12, application number 17.122, request to establish a new level 2 HCPCS code to identify quad shots wheelchair suspension kit. There are no speakers for this item. Are there any questions or comments? Agenda item number 13, application number 17.125, request to establish a new level 2 HCPCS code to identify the Vibra Lung acoustical percussor. There are no speakers for this item. Are there any questions or comments? Agenda item number 4, application number 17.110, request to establish a new level 2 code to identify the JCO. Primary speaker is Mr. Ron Bourgeault.
Well, it worked in the dry run. John, you have any thoughts as to why we're not coming through? Okay. How does lunch sound, folks? We're going to continue to work here and see if we can make this happen.
Okay, so we're going to take a lunch break now while they work on this, and if you could please return at 1 p.m., we'd appreciate it.
No, that's okay. It happens.